Okay, let us start. Let us start continuing with discussion with the tuberculosis. In last class, we had discussed something about pulmonary tuberculosis and how we can diagnose. Right now, just for recapitulation, uh, we have many ways to diagnose tuberculosis. For active tuberculosis, we have the modalities of diagnosis include microscopy, culture and sensitivity, immunological diagnosis, and finally the molecular diagnosis. Now let us again look back at the algorithm for diagnosis of pulmonary tuberculosis. I had already discussed about this algorithm in the last class, that how we are able to diagnose in a case of pulmonary tuberculosis. So the presumptive diagnosis based on the clinical signs symptoms, then we look for the sputum examination of the patient, we look for the microscopy, and if acid fast bacilli is seen, then we need to confirm whether it is actually mycobacterial, or not. So if it does comes out positive, then we need to ascertain whether it is actually mycobacterium tuberculosis or not. So we can ascertain by either culturing the same, or we can go for direct molecular diagnosis, either by the cartridge based nucleic acid amplification test CBNAAT, or by conventional PCR. The other way around is we can go for the culture, whether it's a solid culture or liquid culture. Solid culture gives the results within about 1 to 2 weeks, and liquid culture, and in case of solid culture it may take up to 8 weeks of time. And if we fail to diagnose or confirm microbiologically, we can still classify the patient as clinically diagnosed tuberculosis based on the other evidence, mainly clinical or radiological evidences. Now this becomes very important if the patient is already suffering from HIV. The reason is very simple. I'll just give you an example. Normally we can find the tuberculosis infection to be of chronic origin, and suppose for an example, subcutaneous infections of tuberculosis in an immune competent patient resultly present with an abscess, which we called as cold abscess. Why we call them as cold abscess? Because in other infective diseases, let's take an example of staphylococcus, it can also cause abscess, but in that case scenario, the area that is affected will have signs of inflammation, vigorous signs of inflammation. That is, the area would be tender, it will be a painful swelling, and will be reddish in color. But the same immune competent patient, if the abscess is due to tuberculosis, then the abscess we call it as cold abscess, because it is devoid of signs of inflammation. The area may or may not be tender, or may not be painful, but the reddish coloration, all these features are not present. That is the reason why we call it as cold abscess. However, if the patient is immune suppressed, for example, patient living with HIV infection, because they are immune suppressed, the presentation now changes drastically. The same abscess in an immune competent patient presents in a more chronic, milder form, but in case of HIV patient will present like an active abscess, or like similar to that of staphylococcal abscess. Similarly, even pulmonary tuberculosis presentation in HIV patients are also different. It may present in an indolent fashion like in immune competent patient, if the patient immune status is still preserved in spite of HIV infection, and if the immune status is grossly altered, it may have varied presentations. Now, a very important part is that I have already told you is the CBNAAT. Why? Because the CBNAAT also not only allows us to detect whether it is caused by Mycobacterium tuberculosis complex or not, but also can test for presence or absence of rifampicin resistant gene. Why this is important? Because see, the first line treatment of tuberculosis includes 2 months intensive phase followed by 4 months of continuation phase, and the most important drugs are rifampicin and isoniazid. Many patients, especially in India, are found to be infected with tuberculosis bacilli, which are resistant to rifampicin and isoniazid, and we call them as drug-resistant tuberculosis. Now, drug-resistant tuberculosis, because we need a prolonged therapy, many a times if we don't test them, we will be treating a drug-resistant tuberculosis patient with the drugs which they are resistant to. That is the reason why now it is very much important that you go for molecular testing, at least go for the CBNAAT testing, which will not only allow you to detect or confirm microbiologically, but also help you detect drug-resistant tuberculosis right at the early phase of diagnosis. Now, coming to extrapulmonary tuberculosis. First, you have to understand what is extrapulmonary tuberculosis. The natural route of infection is through lungs. The primary focus, the primary complex occurs in the pulmonary bed, and if the infection progresses, then we call it as primary tuberculosis. If it reactivates, we call it as post-primary tuberculosis. All are pulmonary tuberculosis. Sometimes from the same complex, the bacilli may disseminate into any part of the body, any part, and cause the disease over there. All those we call it as extrapulmonary tuberculosis. It may breach the blood-brain barrier and cause meningitis. We call it as tuberculous meningitis. It may enter into the cerebral blood circulation and cause an abscess over there. We can call it as tuberculoma. It can cause osteotuberculous osteomyelitis in any of the bones. It can cause infections of any organs, including reproductive organs, endometrial tuberculosis, ovarian tuberculosis. Even it can cause specific tuberculosis in some areas, like we call it as pleural tuberculosis. Now, pleural tuberculosis is not the continuation of pulmonary tuberculosis. Rather, the inflammation occurs in the parietal pleura. So, if the bacilli has reached parietal pleura, that means it is not directly from the pulmonary bed, but rather by hematogenous or lymphatic spread extrapulmonary. So, if you suspect a patient is having extrapulmonary tuberculosis, that means there is an ongoing pulmonary focus also. Now, the problem with extrapulmonary tuberculosis is, first is you need to look at where the infection is happening and how you can collect the sample. For example, if you are suspecting the patient is having tubercular meningitis, the sample would ideally be the CSF. Similarly, if we think that the patient is suffering from, let's say, endometrial tuberculosis, it will be the endometrial that is required to test for. Similarly, if we suspect a patient is having tubercular lymphadenitis, that is inflammation of the lymph node, we need, what sample we need to take? We need to take the aspirate of the lymph node itself. Now, problem with this are the number of bacilli in these regions are very less. So, many a times by microscopy we miss them. Okay. So, in these scenarios, the molecular test become even more important. So, if we look at this, if we have a patient who is suspected to have extrapulmonary tuberculosis, then we take the appropriate specimen from the site, whatever may be the site, depending on the clinical manifestation of the patient. Then we need to decide whether the CBNAAT testing is applicable or not. It's not the question of availability, it's applicability. Keep in mind, all samples cannot be tested by CBNAAT. CSF can be tested. We can take the CSF and test for CBNAAT. Like endometrial tuberculosis, can we test endometrium? No. So we need to ascertain whether the same specimen we can apply for CBNAAT or not. If we can apply, then the diagnosis becomes even more straightforward. Either tuberculosis bacilli will be detected or not, and if it is detected, whether it's a resistant or not, it can be the answer. But keep in mind, in some of the specimens, if it can detect, that fine. If it fails to detect, that doesn't rule out the infection. For example, if I am suspecting a patient is having tuberculous meningitis, I take out the CSF sample, I send for the CBNAAT testing. If it comes positive, then fine, my diagnosis is microbiologically confirmed. But if it gives a negative result, it does not rules out tuberculosis. Have you understood this? Yes or no? Okay. If we cannot perform the molecular test, then the only test that remains is the classical testing of culture and sensitivity testing, either by liquid culture and solid culture. And many a times we will fail to do either of them. In that case scenario, we have to treat the patient as clinically diagnosed extrapulmonary tuberculosis, provided we have ruled out other possible causes. Now, let us look at this table. First is the most common presentation is a lymphadenitis. This is a tuberculosis of the lymph nodes. We can do, what is the test? First is FNSC, or fine needle aspiration cytology. We take a fine needle, we aspirate from the lymph node and look at the cells. And if the aspirate is available, we can test for both CBNAAT, acid fast, and if possible, we can also go for the culture. In case of pleural tuberculosis, now this is, we are talking about the parietal pleura. So what would be the ideal sample? It's the pleura. So the best sample would be a pleural biopsy. But problem is, we need to locate the lesion. That is very difficult to locate. Alternatively, we need to take pleural fluid, because any inflammation in the pleura will result in accumulation of the pleural fluid. Furthermore, look over the first option is the CBNAAT of the sputum. Why? Because extrapulmonary tuberculosis is a dissemination by blood or lymphatics, but the primary focus is lungs, that is the pulmonary bed. So every time a patient is having extrapulmonary tuberculosis, that means there is reactivation. You have to rule out whether there is reactivation in the pulmonary bed or not. We can do that either testing sputum or getting a radiological evidence. Okay. Similarly, for abdominal tuberculosis, it could be intestinal, it could be nodal, it could be abdominal lymph node. We can use radiological investigation like X-ray, CT scan, USG, and if possible, we can also go for the radiologically assisted aspiration. Those are very difficult, especially in the retroperitoneum, but if possible, we can do that. Now, I have already told you about tubercular meningitis. The other would be the bones and joints, including tubercular osteomyelitis. In those cases, radiological evidences are even more prominent. Now, another type of algorithm that you should be acquainted with is how to proceed if you are suspecting drug resistant tuberculosis. Why this is important? Suppose a patient is undergoing treatment for tuberculosis, either pulmonary or extrapulmonary, whatever may be the reason, and that patient is diagnosed as a case of drug resistant tuberculosis. All the family members of these patients are at risk of getting infected of drug resistant tuberculosis. Agreed or not? Do you agree? So for them, we need to be more scrutiny of those patients should be even more higher. How can we do that? By this way. Suppose we have a presumptive tuberculosis case and another in which we are suspecting of drug resistant. In both the cases, if it is smear positive, we will do this test, LPA. This is called as line probe assay. This is a assay in which we test for detection of resistant genes that are present in the organism. Those genes are responsible for resistance to both first line and second line drugs. But this line probe assay can be easily done on direct smear. Have you understood? Normally we do susceptibility testing after culture. But suppose if a patient is suspected of having drug resistant tuberculosis, you can do the CBNAAT testing, but it won't tell you anything further. Let me give you an example. Suppose there is a man who is having pulmonary tuberculosis. He was diagnosed as a case of drug-resistant tuberculosis resistant to rifampicin and isoniazid. He is getting treated and the patient is getting clinically better, that is fine. After that, his wife comes to the outpatient department complaining of respiratory symptoms similar to tuberculosis. Now, there is a high probability that his wife is also infected with the same bacteria that her husband is infected with. That means she is a suspect of drug resistant tuberculosis. Now, you can ask the patient to go for the CBNAAT testing, but will it give you a better result? Obviously not. In that case scenario, if a sputum sample comes positive, we can test directly with line probe assay. This line probe assay will tell you whether those bacteria are resistant to the first line drugs used in therapy or the second line drugs used in therapy. Okay, that was the importance of this case. I have already told you about this one. Now, to screen for active tuberculosis disease, the last class where we ended this was how can we screen whether the patient is having the disease or not. Say you can get infected, but that doesn't mean you have the disease. So, how can we separate a patient having asymptomatic disease? We have two kinds of tests for that. The first is called as the IGRA or interferon gamma release assay, and the other is tuberculin skin test or also called as the Mantoux test. Okay. Now, why we should know this? Now, once a patient gets infected or acquires the infection first time, the body gets sensitive to that organism. Now, keep in mind, tuberculosis bacteria is a intracellular bacteria. So, which part of the immune system will be most active? It's the cell mediated immunity. So, cell mediated immunity are mainly, how does they act? By producing cytokines. So, if a patient is infected initially, his body will be triggered. So, next time the patient acquires the infection, the cells which will produce cytokines so that cell mediated immunity can be activated, those cells will increase in number. In interferon gamma release assay, what is the name? Interferon gamma. It is a cytokine produced by some particular cells. Though number of those cells will be increasing. So, if the patient is having the disease, that means these cells will start producing the interferons in higher number. Patient may not be symptomatic, but the number of the cells producing the cytokines will increase. Okay. Now, if you study slightly deeper, you will understand what are the common symptoms that are present in case of tuberculosis. The most important is a low grade fever, right? You will read that low grade fever with evening rise. Why? Because of the production of the cytokines. In the morning time, what happens is the body's steroid levels are higher. That is the reason why the effect of the cytokines are slightly subdued. As the day goes on, the levels of the endogenous steroids go down and the effects of the cytokines then manifest. The patient will come that, well, doctor, I am feeling feverish, especially in the evening. Slight fever, but it is there. This is because of the cytokines. That is the one type of test. One is called the IGRA. What is the other test? Is the tuberculin skin test. So, what happens in this skin test? We take the antigens of the tubercular bacilli and inject the same in the skin. Now, what does the skin have? The skin have macrophages, Langerhans cells, right? Those are the antigen presenting cells. Now, these cells will present the antigen from the inoculum that we are injecting and will process those antigen. So, what the body will do? It will think that the bacteria has entered into the body and will try to contain the infection. So, after about 72 hours, you will find the site in which we have injected the inoculum have signs of inflammation. it will become reddish in color, it will become indurated hard, and sometimes even mild pain is also there. How much reaction will be there will depend on how much the body is sensitive. Theoretically this is all fine, but there is a big problem with this tuberculosis skin test. We can ascertain whether the patient is infected or not. We cannot ascertain whether the patient is diseased or not. One thing, if the patient has prior exposure to the tuberculin antigen, he will mount a reaction. If not, will not mount the reaction. Then we can say he has exposure or not. We cannot say whether he or she is having disease or not. Other way around, we can also ascertain whether his body is able to mount a reaction or not. This is especially important because the number of immune compromised patients in today's population have increased. So the patient might be infected, might be having disease, may not mount a reaction. Okay. So again we will understand the importance of tuberculin skin test in Indian context. When you go out of India where tuberculosis is no more endemic, the context changes. So what are the differences? First is IGRA is a in vitro test. We are looking for interferon gamma release cells. In vitro means that is in the laboratory. But tuberculosis skin test is performed on the patient. That's an in vivo test. The second is in IGRA, what are the antigens? We know specifically what to look for. But in case of tuberculosis skin test, it's a bacterial antigen. We don't know specifically which antigen. We know there are some group of antigens are present. Secondly, we can repeatedly test a single patient for IGRA. But can we do that for tuberculosis skin test? No. Why? I've already told you, it tells us whether the patient has exposure to tubercular antigen or not. Once you are testing, you are exposing the patient. Have you understood? So repeated testing is not recommended. Why? Because it will have a boosting effect. Next, IGRA is not affected by BCG. However, tuberculosis skin test is affected. Now in India, everyone is vaccinated with BCG. That is the reason why interpretation of tuberculosis skin test in Indian context is slightly cumbersome. We can, however, easily test for the IGRA. Okay, these are the other differences. These are the main differences. Okay. Now this is how IGRA test is done. We take the blood sample of the patient, then we collect the cells, and then we look for whether these cells are producing cytokines with immunological reactions. Now coming to tuberculin skin test, how we do that? We take the tuberculin antigen, inject it intradermal injection, and then we look for the reaction. Now coming to the treatment regimes, well, whatever regimens are there in the book, you have to follow the regimen that is been given by the national program that is followed in India. The program is called as the National Tuberculosis Elimination Program. Whatever the guidelines are there, we have to follow the guidelines all over India. Be how to diagnose or how to treat. The common regime drugs that are used are isoniazid, rifampicin. Okay, these are the things I have already showed you. Now coming to the next part of the discussion. Now before going further, let me tell you a little bit history of tuberculosis. I think in last class I have already told you a little bit history about tuberculosis, especially in the era of the Industrial Revolution, because of more and more people were living in a concentrated manner with poor hygienic conditions. More and more people were infected, and at that point of time, obviously there were no antibiotics. People used all sorts of methods to treat the patient, and most of them were failure. So again, at that point of time in the history, people started developing vaccines against many diseases. So obvious attempt was made to make a vaccine against tuberculosis. Until now, the most prominent vaccine that has been used is BCG. Now, what is BCG? It is named by the people who have developed the vaccines Calmette and Guerin in Lille, France, and they have serially subcultured a particular strain of tuberculosis bacilli for a prolonged period. That particular strain is called as Bacillus of Calmette and Guerin, hence called as BCG. That is the origin of BCG. Now, tuberculosis as a world problem, especially in the West, decreased in incidence and prevalence, especially after the Second World War. However, with the HIV pandemic, there is a resurgence of tuberculosis even in the West. And in Asia, the tuberculosis have always and still is a major healthcare problem, further complicated by the drug resistance that has emerged over the last 2 to 3 decades. Okay. Now, for the search of TB vaccination efforts are currently focused in developing vaccines like prophylactic vaccines, post-exposure vaccines, and therapeutic vaccines. Uh, for your context, knowing BCG vaccine is fine, but I just want to broaden your uh, scope of understanding slightly. See, vaccines can be used in many ways. What is prophylactic vaccine? A vaccine which prevents you from getting the disease itself. Like a very good example would be a smallpox vaccine or a varicella vaccine, like varicella is chickenpox. If you get the vaccine, in all probabilities you will not get the infection. Another way is called as post-exposure vaccine. What is this type of vaccines? Suppose you get infected but still don't have the disease, that is in the incubation period. If I give you the vaccine, I can protect you from getting the disease. This is called as post-exposure vaccine. Like the chickenpox vaccine can be used. Suppose you are unvaccinated and you come in contact with a person who have recently got the infection, and then you come to me, so what can I do? I can say, well, you can take the vaccine. Same with the measles. Why? The vaccines will have active pathogen which will multiply and give you the immune boost up before you get the disease. Those are called as post-exposure vaccines. The other way, last part is called as the therapeutic vaccines. What happens in therapeutic vaccine? The patient is already diseased, and if we give the vaccine, we can enhance the immune response of the patient, hence the disease can either cure faster or the symptoms will be milder. Now these are the type of the vaccines. Now if we look at BCG, then what type of vaccine is it? Is it a prophylactic vaccine? Is it a post-exposure vaccine, or is it a therapeutic vaccine? Now over the 100 years of development of over the 100 years of the development of the BCG vaccination, initially the tubercular bacilli were cultured on glycerol and potato medium. Thereafter, in 1902, the tuberculous bacilli of the cow causing bovine tuberculosis was isolated and it was neutralized by serial passages. This serial passage was after about 230 subcultures. This strain was found to be avirulent. Now what do you mean by avirulent? It retains the antigenicity but it does not cause the disease. Then this strain was used to vaccinate everyone at that point of time. Then it was found out that in spite of vaccination, it was not able to prevent pulmonary tuberculosis. And especially in children, sometimes it would lead and cause full-blown tuberculosis also. But what it does gives is that it gives antigenic exposure to human beings. Long story short, in today's time, what does BCG helps us? BCG does not prevent pulmonary tuberculosis. Keep this in mind. If you are vaccinated, that doesn't mean that you will not get tuberculosis. What you will be able to prevent is development of primary progressive tuberculosis and cerebral tuberculosis up to 80%. That's the theoretical data. Have you understood? No. What is primary progressive tuberculosis? That means if we vaccinate a child as early as possible, if that child gets the infection, especially in the infancy, he will not develop primary progressive. That is the progressive tuberculosis without an immune response, because we are already triggering the immune response with the help of the vaccine. That we can prevent. Another important disease we can prevent to some extent is called as miliary tuberculosis. Now, what is miliary tuberculosis? It is total spreading of the infection throughout the lungs. That is also a type of primary progressive tuberculosis that we can prevent. And other one that we can prevent is called as the CNS, tuberculosis of the CNS, predominantly TB meningitis in children. Problem is that we get vaccinated only during the childhood. After that, the immune status of the people will wax and wane depending on the physical condition, other various diseases, medications, it will wax and wane. And when the immune status goes down very much, all of the diseases can be possible, even if you are vaccinated. If your immune status is poor, you can still get TB meningitis. You can still end up with pulmonary miliary tuberculosis. Then comes the question, then should we stop the vaccination? Because technically it is not preventing much. No, because BCG with historical evidence have prevented these dangerous forms of tuberculosis, especially in children. That is the reason why the national program, the universal immunization program, states that all children should be vaccinated with BCG at birth. At birth means within 72 hours after birth. There are some contraindications, like if the child is suspected to having born to HIV mother, etc., etc., there are exceptions. But the rule is every children should be vaccinated. Next is another important aspect of vaccination that you should know is how to vaccinate with BCG. How this vaccination occurs. Any idea? Everyone is vaccinated, right? Everyone, how do you know that? How do you know whether you are vaccinated or not? Is there any evidence? Yes. Leave alone all the scars, and first is you have documented evidence. Scar formation generally occurs. Many a times the scar may not also form. But that doesn't mean that the child is not vaccinated, right? The most important aspect is that you should have a documented evidence of vaccination. Next important question is how to then vaccinate the child. So these are the indications. Newborns and infants are the greatest benefit of the BCG vaccination. In developed countries, BCG vaccination includes infant and children, and who all should also be obviously vaccinated? People involved in healthcare activities, be it vaccination, treatment, or other, especially because with the increasing cases of multi-drug resistant tuberculosis. And I've already told you a vaccine may have three aspects: prophylactic, post exposure, or a therapeutic. Another important aspect is in the treatment of bladder cancer. BCG can stimulate the immune response. In malignancy, immune response is perhaps the most important tool to suppress the disease. BCG has been used effectively for the treatment of bladder carcinoma. Now, whom should we avoid? First person, whom should we avoid? Exactly. Whatever may be the cause of immune compromise, we should avoid, because although this is an subdued strain, but it is still an live strain. Okay. So when we say subdued, that means in a normal immune competent patient, it may fail to cause the disease. But somebody whose immune status is deranged, it may cause the disease, like most importantly HIV. Now, what would be the complications? This bacilli is a intracellular bacilli. When we inject it in the skin, what happens? The macrophages will engulf the bacilli and try to contain it. Obviously, it will fail to contain and will take this bacilli into the regional lymph node, where the antigen will be processed and cell mediated immune response will be initiated. What happens is that lymph node undergoes swelling and inflammation called as lymphadenitis. Most of the time this inflammation will subside on its own, but the skin lesion will progress. Look at this side. Initially, after the injection, there will be a swelling with reddish discoloration, inflammatory response. Slowly, the skin will get sloughed off and we will left with an ulcer. This ulcer will heal by secondary healing. In pathology, we have already did secondary healing. That is the reason why we end up having a scar on the left shoulder region, left deltoid region. That is the normally that what happens, but sometimes some abnormalities may also occur. Like suppose if it cannot be contained, what will happen? It will drain into the axillary lymph node and will cause severe suppurative lymphadenitis. Or the skin lesion, it may end up having skin abscess. Thing that can happen is called formation of keloid. You have read in pathology, right? What is keloid? Jore bolo, jore bolo. Exaggeration, right? It can also trigger exaggerated response that may end up with formation of keloid over the site of infection. So these are the many types of manifestations that you may find after BCG vaccination is given, and sometimes we may end up having infection in the bone itself or dissemination of the bacteria throughout the body. These are commonly seen inadvertently when we give the vaccine to people who are immune compromised. Now coming to vaccination in India, what happens in India? We have the vaccine in the white powder or pellet form. Each dose contains about 1.5 to 6 million colony forming units. What is the dose? 0.05 ml for infants under 1 month of age and 0.1 ml over 1. Why is this difference made? বলো বলতে পারবে? When shall be the BCG vaccine given till last? Ideally, it should be given at birth, right? Suppose if a child missed the vaccination at birth and comes to you at 1 month of age, will you give the vaccine or not? Yes or no? Yes. Now, if the child comes at 1 year of age, will you give the vaccine or not? If the child comes at 5 years of age, no. You have to give the vaccine within 1 year of age. And why the dose is different? Because less than 1 month of child, the children will have very thin layer of skin. That is why the dose is altered. Okay. Now, I think these are all the parts you will be studying in preventive and social medicine about vaccination strategies. Vaccines will have the vaccine vial monitor, and because it's a live vaccine, if the vaccine vial monitor fails, you cannot use the vaccine. After reconstitution, you have to use it within the specified time period, and you have to keep the reconstituted vaccine at a particular temperature. Why all these things are made? To avoid the complications that I have already told you. Now let us look at the normal reaction. After the vaccination, we will find this kind of manifestation about 24 to 48 hours. That is 1 to 2 days. After that, about 5 to 7 days, we have the inflammation decreases, but we can see formation of pus and crust over the area. Then about 10 to 15 days, the whole ulcer heals with formation of scar. Now, why I am telling you all these things? Because whenever you are vaccinating a child, you need to convince the mother that this is a normal healing process. Because no mother will accept having a child with an ulcer on the arm. So, this normal response, you have to make the parents understand why BCG vaccination is important for the protection of the child and what will be the normal consequence. If you can make them understand the normal consequence, first of all, the parents won't panic. Most importantly, the second one, if there is an abnormal immune response, the parents are more likely to bring the child to medical attention faster. Now, similar to BCG vaccine, we have the tuberculin skin test or MANTU test. So, what happens? Acha, before talking about tuberculin skin test, there is a dictum in India that BCG vaccination is given on the left arm at the region of deltoid insertion. This is the norm in India, so that a degree of uniformity can be maintained across the country. But it doesn't mean that you have to give on this side only. You can give on the other side. What could be the reason? If the child is having any kind of skin lesion over that area, you can't give a live vaccine on an affected area. That way, you can also give on the right arm. Okay. That is the reason why I have told you most important part is documented evidence of vaccination. Okay. So, similar to BCG vaccination in MANTU testing, what we do that in the first visit on the left arm in the ventral aspect about midpoint from both the joints, we inject the dose of the tuberculin bacteria. Then we tell the patient to go back to home. After that, about 48 to 72 hours, we recall the patient, examine the site, and we measure the size of induration. What is induration? It is the hard swelling. Sometimes we may find inflammatory reaction around the induration. So this is the induration, okay? We may find reddish discoloration. We will not consider the reddish discoloration. We will only take into account the swelling part, that is the indurated part, and measure that. and note it down. When we are going to note it down? About 48 hours to 72 hours. An induration of 5 mm or more is considered positive for people living with HIV. Try to understand this point. Why? Because a patient who is having active HIV infection is not meant to show that kind of immune response. If he or she is showing that kind of immune response, that means there is an ongoing pathology going inside the body. Similarly, patients who were initially have no exposure to the tuberculosis bacteria but have recently come in contact with other patients who are having tuberculosis. Other like people with organ transplant or immune suppressed patients. If the induration is 10 mm or more, we consider it as positive in which type of people? People born in countries where tuberculosis is endemic, and you can find the name of a country over here. This is for immune competent people. Other would be people who abuse drugs, people working in the laboratory handling tuberculosis samples and cultures, people living with high risk disease like diabetes mellitus, renal diseases. This is important. People who are malnourished, both children and adults. Finally, if the induration is 15 mm or more is considered positive in persons with no known risk factors of tuberculosis. Okay, suppose a person who is from a country like say US or New Zealand, it is unlikely that he will come in contact with, not from a medical background, so no exposure to the patients, unlikely to have a infection, not disease, even infection, and shows an high induration, then we will also consider this patient is at high risk of developing tuberculosis. Okay, keep in mind this is not a diagnostic test, this is only a risk assessment, and it helps in diagnosis of latent tuberculosis. What is latent tuberculosis? The disease is ongoing, the patient is asymptomatic. Okay, I can't find the video. In the next class I will show you a video which shows how this BCG vaccination is given to a child and how to observe the child. Okay, I can't find it today. Nevertheless, so that was in gist everything about tuberculosis that you need to know. Okay, so what you need to know is the etiological agent. Let us recapitulate or try to understand in a contextual basis. So what would be the etiological agent? Etiological agent is a tuberculosis. It's a complex, it's not a single organism. Okay, it is caused by Mycobacterium tuberculosis complex. There are about 6 species, if you can remember that, fine. Other than that, the same type of disease can be also caused by other mycobacteria. Those are called as the NTM or non-tuberculous mycobacteria or atypical mycobacteria. Clinically, we will classify tuberculosis in the 2 broad categories. The first category would be pulmonary tuberculosis, the other would be extrapulmonary tuberculosis. The reason is very simple, the mode of infection is through the respiratory route. The primary complex that forms is in the pulmonary bed. It is also called Ghon's focus, then it spread to the lymph node, we call it as Ghon's complex. Okay. Typical or classical description of pulmonary tuberculosis will be affecting the upper lobe, but it can affect any part of the lung. Typical description is a cavitary tuberculosis, but other forms are also present. Extrapulmonary tuberculosis occurs when the same bacteria reaches other organs, either hematogenously or through the lymphatics. Any organ can be affected, from CNS to musculoskeletal system to GI system, anything. Keep in mind Pleural tuberculosis is a form of extrapulmonary tuberculosis. Okay. Coming to symptoms, it will depend on the organ that is affected. If it is affecting the lungs, we will have pulmonary symptoms which can range from coughing to expectoration to hemoptysis to respiratory distress. If it affects other organs like the brain or CNS, you will have neural manifestation. If it affects the bones, it will have orthopedic manifestation, etc. and etc. Coming to diagnosis, diagnosis is done by clinically we look for the signs and symptoms. Next, we need to confirm microbiologically, by which we confirm with sputum microscopy or sputum or any sample microscopy, which we can do with acid fast staining because the bacilli is an acid fast bacilli, or we can also look for histopathological examination. Next modality of microbiological confirmation would be to get a culture done. The culture and sensitivity could be done either with liquid culture media or solid culture media. Advantage of liquid culture media is a quick turnaround, about 1 week. In solid culture, the turnaround is about 2 to 8 weeks. Because the culture and sensitivity takes a lot of time, newer modalities are very important. The newer modalities commonly involve diagnosis with nucleic acid amplification tests. Closed methods or cartridge-based methods are recommended even by the national program, which includes the use of the GeneXpert by Cepheid or TrueNAT by Molbio. Alternatively, we can use the classical PCR methods also. The purpose of these molecular methods is not only diagnosis but also identification of resistant genes, or if they are present or not, for identification of drug resistant tuberculosis. An important aspect of diagnosis is identification of patients who are suspected having drug resistant tuberculosis. Which category of patient will be suspecting them? Mainly people who are immune compromised, be HIV or other causes of immune compromise, and people who have exposure to drug resistant tuberculosis. Okay, that even includes healthcare workers like us. Coming to the treatment, first line and second line drug therapy has been established, and even drug resistant tuberculosis regime are also there. I am not going into the details because it will be too much difficult for you right now. Next part of the diagnosis would be, if we can't get microbiological confirmation, we have to categorize the case as a clinically confirmed tuberculosis based on the clinical examination and other modalities like radiological methods, be it a chest X-ray or a CT scan or an X-ray, etc.